like
your brain is making, like they're making it up. No, 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 no.
They're not.
Your nervous system is remodeled and it's not working. Like
it's not the same. Like
I'm proving this to you.
Yeah.
Like, and so yeah, because I think that's one of the things in the early in the pain sciences. You know, you say because it used to be if you don't explain it well, then people can take it like this.
And then that hurts them more because
correct.
It deals with their psychological.
Especially if it's a dude.
Crazy.
Especially if it's a dude telling a woman it's all in her head, because then we kind of hear from that stuff.
Yeah.
There's a little bit of like micro trauma stuff, like for lack of a better word. So, but yeah, that's it. That's like pretty typical of somebody like her with that 15 centimeters.
Starting momentarily.
Hannah, I think she'll be, I'm going to see her on Tuesday. Okay. And then, I'm going to go grab food really fast.
Third.
And then
10-4.
so she basically, she just has generalized pain. She's got persistent pain, patience. She's cerebral nervous. She's just super sensitive. She's got sciatic nerve restriction, so I don't think
Hi, Isabella. Hi, Misty. Welcome to our Thursday afternoon presentation. Tonya is chatting up with Hannah right now. We're going to start in a few moments here. Hello. Hello.
she needs to be touched, and she's sensitive.
So we got all of you.
Yeah. Just not on her side. Yeah. Well, right. Well, and that right shoulder, she's got the hammer head is anterior. So we can just loosen all the stuff up. Be gentle. Be gentle. She just needs touch to like desensitize. But the thing I was just going to do like the straight leg raise stuff.
Best day fitness is live. We're live up in the joints.
So I can even do like a, I've been loving this touch her. Static people like just block them up. Like a, sorry, explain that again. Like if you're on your
Yeah, I had it muted. Nobody was talking. Sorry, it's on now.
And then she also might need a nutritionist.
Oh, cool.
So like maybe take note.
Okay.
She was keto and she actually was. Because if I don't tell other people, then I'll forget and then I'll miss it. Okay. Next. Sorry, guys. So she, that was just because I actually would have been on time, but.
Oh, no, I started it for 1:15.
Oh, okay. Oh.
And she got here late.
Yeah, she was a little bit late, so I was planning on being not late. Okie dokie, schmokies.
So Isabella and Misty are watching our live stream. So they are here and they are asking questions as needed
Okay.
via me. So I will let you know if they answer any or ask any questions.
Okay.
Yesenia's grabbing a snack. She'll be right
What are we
back.
doing? What are we
Same with
doing?
Hannah. She's grabbing her shirt. Yesenia's not.
Ugh.
Yesenia is not here. Sydney is and Yesenia. I promise things are happening. Things are happening.
Things are happening. Where do I need to be?
Perfect. You have that whole area. You have the table, you have a TRX. You can take that off. We are now officially
Do I need to
all
qualify it with I am fully vaccinated as of March 24th? We're being mindful of COVID, blah, blah, blah. We're not being
If you guys have questions, here is
uncareful.
the microphone. So instead of like Tonya answering like phantom questions when you guys ask questions, because nobody can hear y'all. So just grab the mic. I'll put it right here if you have a question to ask.
Or I can repeat the question.
Or
You can maybe help me with that as well. Okay, so today's topic is
Knees and hips.
sweet.
And how the knees affect the hips and how the hips affect the knees and how
The
we
knee
can correct
bone.
valgus and varus imbalances or some of the muscle interactions that cause valgus and varus positioning, how the glute medii are affecting the knees and the hips. And yeah, I think that would be a good place to start just because I think there's a lot of newer trainers that might I know it took me a long time to figure out how to affect one without messing up the other, if you will,
Right.
and vice versa.
Yes.
So I think that would be a great place to start. How, maybe going over, what happens when the knee goes out of neutral, either valgus or varus, and how it affects the chain above that, and the hips above that. And I think that would be a good, I think I'll just spin the top and let it go and see what happens.
All right, let's do our, just do what we do. Because we brought in a couple other people. So this will be like review for a lot of you, which is actually kind of fun because that means you're gonna have a little bit more of a complex understanding of it, especially with regard to like patients or clients are concerned. And then Kwame, like a lot of what we're gonna talk about has to do with the client that I saw, of yours that I saw the other day when I remember I was talking about anyhow. So I don't have to send you the video because we're just going to go through it. Knee 101. Understanding anatomy is critical for anytime you're working with humans in any sort of a health or fitness way, especially if you're doing exercises, because you need to know what is happening. So let's just go and start from the beginning. The knee is a hinge joint. It is made to bend and to straighten. It is not made to do anything other than bend and straighten. It's supposed to bend and straighten. Bend and straighten. If you add anything other than bending or straightening to the routine, such as rotation, then you're taking it out of what it is made for, and you are putting it at risk for injury. So the most common issues with the knee, or even the low back, is introducing shearing forces, which is where a bone is sliding on, or a surface is sliding on another surface. So shearing forces, that's a term to be aware of. And rotation. So in the knee, when rotation is added into the movement pattern, you're causing the bones or the cartilage to shear in a way that increases friction and increases the chance of injury. So more commonly with knees, you have the valgus. So now if you can see the knee here, if I'm going to load my knee, my femur is going into adduction, and it's also flexed. Adduction and internal rotation is happening. And now if I load it, which part of my knee cartilage or knee surface is having increased loading and shearing forces? The outside or the inside? The inside, and or medially, that's where the most common area for cartilage degeneration or injury happens, is medially, because of the valgus force. And it's not because the valgus, so actually a student brought this up to me, reminding me of this. There's no such thing as a valgus force. If you want to be technical about your use of the terminology, you have gravity that is coming from, that is pulling from up to down. So it's vertically this direction. And then you have the ground reaction forces that are coming from the ground up. So when you put your foot on the ground reaction forces are going vertically up. The gravity is coming vertically down. So any way that you have forces that are outside of that perpendicular arrangement, that's where you're going to be ending up having either a varus or a valgus force. So the varus or valgus force is not something that's coming from here. I think sometimes people
misunderstand.
Unless
it's a football player falling into you, that would be like...
That would be impact.
Right.
Yes, that would be causing... Okay, that's where the misunderstanding of the term is. Yeah. If there's impact, that is causing a valgus force. But there isn't a valgus force out there that makes the knee go in, or a varus force that makes the knee go out. It comes from the lever arm of the femur, which creates a valgus moment in the lever arm. Not to traumatize you all with physics, but just if anyone starts like, oh, flashing back, oh my God, physics. So I think just basic understanding of lumbopelvic and knee anatomy, how they're all intimately connected, is if you, and lesser experienced clinicians or students that I work with on a regular basis, when they're first starting to look at movement, they look distally, because distally, which would be at the end of the limb, is where the forces are significantly magnified and a great deal more obvious. The experience, and so then they'll say, oh, your foot is going into pronation, so that's what's causing your knee pain. If you actually do the math, and you think about the lever arms of the tiny little bones of your feet, the tiny little muscles in your feet, and the lever arm of your lower leg bones compared to the lever arm of your massive femur and all your glute muscles, it doesn't make sense how your foot can be the primary driver of knee issues. But it's the most obvious if your eye isn't as experienced and skilled. So I always encourage people, this is really great, because when you're first learning how to look at something or analyze movement, first you need to see something. So I'm like, sweet, you saw something. You saw something in the foot. But as skilled clinicians or people with experience, you need to think to yourself, that's the symptom. it's not the perpetrator. So the symptomatic tissue is not the perpetrator, it is the victim. What you see distally is not the perpetrator. It's the symptom of what's going on proximally. So I guess if we had like one tagline that we could have at Best Day, it would be like, look proximally. So if you see something distally, look proximally and address that, because that is how you're going to actually create meaningful change in whatever symptoms that you're having. So you see somebody collapsing in on the arch of their foot, and then their knee is going into valgus, and let's just define valgus and varus. The definition of valgus is going towards midline. Varus is going away from midline. I can't remember the Latin, the actual definition, but I had to look that up just so it makes sense. So valgus is anything that's coming towards midline. If an angle is coming towards midline, varus is coming away from midline. So you can have varus and valgus in the elbow, valgus in the elbow, varus in the elbow, etc. So just random definitions of those terms. So if you're looking at somebody and they're doing a squat and they're doing this, or actually they're doing this, looking at the foot is fine, but ideally the foot triggers you to look up north, ideally at the pelvis. Because if you think about it, if your pelvis is, and I can't remember the data, it's exponentially. If you have a 5-degree drop of the pelvis, translated through the femur, which is like in some people it could be like 3 feet long, it's exponent. The forces are increased exponentially down into and through the knee with adding, and if you're valgusing at the knee, you're getting internal rotation and adduction, and then your body weight and that exponential loading through that knee. That's where people are having the knee pain. So thinking about remediating that valgus force, it's really simple. Look up here and create strength and the glute medius is the easiest muscle, or it's the one that's the easiest and most commonly the one that's impaired or dysfunctional and allowing for valgus, because valgus is adduction and internal rotation. So if you can see anatomically what is happening with the person that you're looking at, and if you know the muscle actions in the body, you can say to yourself, what muscle does the exact opposite of what it is that I'm trying to stop? So we have adduction and internal rotation, which we want to have not happen anymore because it's hurting the person. They're like, my knee hurts when I do this. Well, then don't do that anymore. So your job is to bring their knee, their hip, or their femur into the opposite movement, which was abduction and external rotation. And if you get a butt cramp, if you know your anatomy, then you will say to yourself, oh, the glute medius does abduction and external rotation. The glute minimus does to some degree, but it's a tiny little guy. And the glute max in a particular position will help with external rotation. But the glute max primarily does hip extension. And so understanding your anatomy and being able to identify what is happening, then it's easy peasy. Does that kind of make sense? So I know we went through that handout on the sideline glute med series. I'd kind of like to get away from the side, like the non-weight bearing stuff, because in the grand scheme of things, if somebody is so weak that they need to be non-weight bearing, I need to be on board, because there needs to be some diagnostics happening with regard to motor pattern and all that and blah, blah, blah. So let's talk glute med in the standing position. Glute medius, what motion does it do? So just knowing that it's this. Now, what's the other thing that we need to know if you're trying to affect a particular muscle? What is the most common compensating or what's the word? Not synergistic muscle. What's the most compensating muscle that's going to try to help out but actually steal the thunder? So the key to the glute medius is it does abduction and external rotation in slight hip extension. So you need to have, yes, so you need to have slight hip extension, which is why I'm kind of steering people away from doing the side lying like the Jane Fondas, because most often people compensate, they bring in the hip flexors. So you have to be, it's not practice makes perfect, it's perfect practice makes perfect. So if you're going to do, and I used to, that was my riding instructor, Violet Hopkins, used to do that, I'd roll my eyes and she was right. So when you're doing your abduction and external rotation for glute med strengthening, if they're coming into hip flexion, you're not doing what you're trying to do. Now you've got a hip flexor that's super strong, and now we'll continue with our anatomy, understanding of anatomy. What's the hip flexor that most influences the knee? There's one of them.
Rectus femoris.
Oh, sorry, I think you said quadrotus.
Yep, yeah, which I said hip flexor. And that is it's the only, it's the only quad that is a hip flexor. So rectus femoris goes from the ASIS down to the other side, out to the tibia. So it's the only quad that crosses the hip and the knee. So if you're overusing your hip flexor, if a muscle is being used a lot and is fairly strong, does it tend to be longer or shorter? Shorter. So if we have a shorter hip flexor on that side because they're overusing it, is that going to allow the hip to go into that 5 to 10 degrees of extension in order to get the glute medius even firing? Nope. So also knowing not just the muscle that you're trying to activate to do the opposite of the movement, to correct the movement that the aberrant movement that you're trying to correct, but also then knowing what the compensating patterns are. So knowing the planes of motion that the joints and the muscles act in is that second layer of understanding of things. So you see somebody, so that's probably the biggest thing, is that the hip flexor, the rectus femoris, then confounds everything. So that's a good question. So let's talk about TFL. Where does the TFL go? It comes from here.
What was the question again?
Oh, sorry. The question was, would you want to watch for TFL firing, overly firing? And that's a good question, and it's probably the most common question people have, especially when we talk about hip flexors. But if we want to talk about, let's go back to our anatomy. The TFL goes from like the iliac crest, anterior superior iliac spine, crosses the hip joint, but then it blends into the IT band. So we've got the TFL, which is also anterolaterally, so it does external rotation, but since it's on the anterior surface of the hip, it's hip flexion, a little bit of external rotation, depending on what position that you're in. Yeah, yes, it depends on what position that you're in. But the bulk of it, it depends on how much hip flexion that you have. The bulk of it is going to hip flex. But the real answer to the question is understanding anatomy. You've got a muscle that's this long and crosses one joint compared to a muscle that's this long that crosses two joints. So that rectus femoris is more of a power player. The TFL is, again, when people concentrate on talk a lot about the TFL, to me that shows a little bit of less understanding of anatomy and kinesiology and kinetics, because it's just not a power player in the movement pattern that we're talking about. But it is a hip flexor. So, but also kind of going off on a tangent too, is just remembering that symptomatic tissue is the victim, not the perp. So when people have tight hip flexors, do you think it's because they're using them too much or not enough? And what's the most common movement pattern? What's the common? Yes, too much. So the muscle is tight, it's overused, and it's symptomatic because it's doing more than it needs to because somebody else isn't doing what it needs to. So more often than not, that glute medius is the one that's not kicking in, and the hip flexors get blamed for all sorts of things. But it's easy to blame the victim because you need to have less knowledge. Just poke around on that tissue that's inflamed, and then people think you're helping them, and like you're not getting to the cause. But there's a time and a place for reducing that tension. So Hannah, when you're doing massage, ideally you're releasing those tissues that are overused. If they're released, they're gonna kick in less, and then you educate the other side to actually do what it does. That's when you get like the full meal. Yeah, that's when you're doing it. Now you're money. Now you're really helping people get to the cause, and which is physical therapy. We're like, get to the cause. Okay, so let's just review. If you see an aberrant motor pattern or movement pattern or joint angle that seems that you want to make not happen anymore, just dig into your anatomy. So if the knee is going into internal rotation and adduction, you should think to yourself, which muscle does the opposite of that? You can Google it. It's not that hard. Google muscle that does external rotation, abduction. So we got that action, external rotation and abduction, but then also remember the plane of movement that muscle has to fire in, and then the compensating muscle that wants to actually do its job. So does that all make sense? So we're talking glute med in the standing activities, so you're going to see it most often. So when you're watching somebody do a squat, when you're new at watching people do squats, you're looking at their feet and their ankles and their knees, and you don't see anything above that. You guys have been doing this long enough that you can see a pelvis that's off. And that's where looking at somebody from the three angles, you look at them from the front and you're screening primarily for where their knees are, because it's the easiest to see the knees from the front, right? You can see the pelvis a little bit, but there's just a lot of other stuff. I mean, you can't really see the pelvis here because it's, creased, especially if they got a little something going on there. So now we look from the side. What does the side tell you about? Let's go for just waist down. So we've got this. What are you primarily seeing from the side if we're looking from iliac crest down?
Calf tightness?
What just changed? Do we know it's calf tightness?
Or calf?
Not yet,
right.
And now granted, I'm diagnostic, not everyone's diagnostic, but that is something to take note of. You may cue the person, are you able to keep your heels on the ground? If they're not able to keep their heels on the ground, the easiest thing for you to screen for as to whether or not it's ankle range of motion, which could be calf tightness, which could be something going on in the joint, is just place something, which is what I wanted to talk to you about, underneath their heels. And if they can all of a sudden magically pinch my fingers, so I would tell you, and this is in your scope, this isn't diagnostics, somebody they do a squat and they're here, and it's usually, you know that's going to happen. It's usually a strong guy with big muscles. And so they do this, and you wanted to be doing deep squats with them, but their heels come up. Bring the ground to their heels, so accommodate that loss of range. Now if they can magically squat, you know that it was their ankle range of motion, and that's what this client that we talked about that I saw the other day. I want you to do deep squats with him with the heels lifted on a sturdy surface. Don't use something soft because then he's too unbalanced. Right. And I want you to have him loaded. So if he's loaded, you don't want a dynamic surface. I want him heavy and accommodated. And the reason I'm saying that, I need to show you how to look at the person from the back. So stay on task. Let's make a bookmark on what I was just about to say, the reason I'm doing a deep squat. So somebody remind me circle back to
We
that.
don't know what you were
okay?
about to say. What do you want me to remind you of?
Why deep squats?
Why deep squats? I wrote it down.
Perfect. Okay. So now just to review, the front view of a squat, you're mostly looking at the knees and the feet. I just got dizzy. Whew, I need lunch. The side view of the squat, right now we're doing like in physics where you dismiss half of the variables. We're only looking at the person from the iliac crest down because otherwise I'm trying to stay on task here. So from iliac crest down, when you're looking at a squat, you're primarily looking at ankle range and hip range, but primarily ankle. So if you support the heels and they can ass to grass, you know that it's an ankle range. And then just accommodate it. Now, looking at somebody doing a squat from the back, now you can really see, this is where you want to be able to see their pelvis. This is where you can actually look at, you can see the pelvis obliquity. If their pelvis is wonky and they're doing, and the motor pattern, that valgus is coming more from an unevenness in the pelvis, that's really obvious. So I would just use these three, the cues, to kind of educate your eye. When you're looking from the front, you're primarily looking at the knees and the feet. When you're looking from the side, you're primarily looking at what's going on at the ankles. And when you're looking from the back, you should be primarily looking at the pelvis and whether or not it's wonky, it's the pelvic obliquity. You can see if they're guarding, if they're loading one side more than the other, but I would encourage you just to look at the same places every time you have them do those movements, because that'll educate your eyes to see the particular thing that you're trying to pick up on. So we just talked a little bit about accommodating the ankle, and that's perfectly fine for you to do. If you're accommodating the ankle and it's a supportive surface, that's safe. Don't accommodate the ankle on a wonky surface because then people can be unbalanced and there's a chance for injury. So, why do we want to do a deep squat? Yes. So let's go back to and it could be, this is a little
What was the answer to lengthen the rectus femoris?
Yes. So
Good
think
answer.
about it. Rectus femoris. And we're talking about the rectus femoris because that's commonly the most commonly tight muscle that is affecting the ability of the glute medius to fire and activate and come out of that, help that knee out of the valgus. So if rectus is tight, you cannot get into hip extension to actively use your glute medius. Rectus goes across the hip and the knee. So if you're in full ass to grass squat, not halvesy squat, all the way down, which is why I need you to get the client from the other day, ass to grad, load the hell out of him. He needs super loaded but on a stable surface. So with a barbell, heavy loads. Meaning he can do you are correct, but it was a different context. So you're not going to ass to grass with a barbell and plates. That's what I was talking about. So thank you for remembering that. Yeah, this is not safe if you got a bar. Well, I mean, they're going to tip over. But if you've got a kettlebell, oofta, I'm going to do the easy one. Sorry. If you've got a kettlebell and you're here, this is actually safer because you're centrally loading. And then this particular client, you're doing this, you're addressing his shoulder stuff. I need food. Okay. So, or you can also do, it'll pass. Or you can be here, loading. This is safe. But if you've got it on your back and they're going to tip over, that's not safe. If he physically can't bend his ankle,
There's nothing you can do other than accommodate it to get him. That's the only way he can get into a deep squat. Okay. Wait, where is I? Okay, so. Yeah, I guess you can do this, but this isn't gonna. Static stretching doesn't
go back to...
do anything.
You heard it here first, folks. Actually, we had somebody ask us about that earlier on our live stream. She was like, "Should I warm up with stretching?" And I was like, "No."
Well, now.
I mean, depends on
if you're better off
dynamic stretching,
doing the particular activity that you want to do slowly and unloaded. So if you're going to run, the best way to warm up to run is to jog. I mean, you can do, if you're a high level runner, you can do some of your dynamic stuff, but the average person, just do whatever, because the reason I'm saying static stretching is what you don't do before you work out, because static stretching actually makes the muscle have less strength, and it stimulates the Golgi tendon the Golgi tendon organ, and actually makes that muscle less responsive. So it increases the chance of injury, which is why you don't do a massage before and turn the nervous system off and then do a big workout. Like it just, yeah, so.
Dropping bombs over here.
Yeah.
Hey, we could probably talk about stretching for hours.
Yes.
Why deep squats? Did we need to get back to that?
Yes, so the deep squats, we're talking the deep squats because we're going back to that rectus femoris. I'm all about, you guys too, are bang for your buck. Especially the clients that come in here, they want to come in here and they want to get their ass kicked. They want to work, they want to do stuff, so you want to be doing multi-joint, multi-body, functional activities. That is where you're going to get the most, people are going to feel like they're getting the most out of what they're doing, and you're going to make the most meaningful change for people. And you don't have to have me telling you what to do, because you're doing a lot. It's better. So, ass to grass, you're getting, I know it seems like you're doing a squat, and because the hip is flexed, your first thought would be, I'm not challenging the hip flexor. You're challenging the rectus because you're fully lengthening it because the knee is fully flexed. So yes, it is approximated at the hip, but it's elongated for the vast majority of the rest of the. Where is mine? Nobody breathe.
Nobody breathe.
Nobody breathe.
Bye, Karen.
I'm vaccinated. Where is mine? Anywho. So does that make sense? So the best way to increase the length of the rectus femoris is to deep squat. And what's super awesome about the deep squat is it does, what else does it do? You're getting, okay, so, so we're getting, so let's go through our anatomy. Hips are maximally flexed, knees are maximally flexed. As you're standing, what is happening?
You're using your core to keep your...
Let's go from the feet down. Who's acting right now? What am I doing? Wait, let's go through our joints. My knee is doing what? It's going from flexed to extended. So what muscles extend the knee? What muscle group? The quads. So my knees, I'm just going to do this, paint by numbers. Knees are extending. My hips are extending. What muscles primarily do hip extension? What muscle group? You know it's the glutes. Don't doubt yourself, for God's sake. The glutes primarily perform do not doubt yourself. The glutes primarily hip extension. They can do a little bit of hip, the glute max can do a little bit of hip external rotation, but we don't need to worry about any of that yet. Okay, so now that was the main. So what do the hamstrings do? So the hamstring does knee flexion. So when is the hamstring working during a squat? It's flexing, so it's not, is it active right now? Do you think? Yeah. It's kind of a trick question.
Yes.
How active is it? It's not creating the knee flexion right now. Gravity is creating knee flexion right now.
Is it helping to control anterior and posterior tilt of the pelvis? I mean posterior, well, it's helping the pelvis to stay more neutral, or at least, because I know with tight hamstrings, it's going to help pull that pelvis in the posterior, right? So if you're squatting and your hip or your pelvis is, maybe they're posterior tilters and their hamstrings are.
So in this position, I hear where you're going with that. Let's just problem solve.
I might be getting a little too like dynamic with like it's more like stabilization role versus it's helping with the movement.
Is the hamstring loosened? Is the hamstring shortened or lengthened right now?
Shortened.
When the knee is flexed?
Shorter.
Meaning it is not active very much. So if it's shorter, the effect that it can have on the pelvis here is going to be less. However, that's not a wrong thing to be noticing, but it's not a primary something that's happening here. So Sydney, tell me again what you were saying. I know. I'll remind you. So we were talking about what we're pontificating on what the hamstring is doing during the squat.
It works antagonistically to the muscles on the front side to just help it balance and not.
So what's one word you can use? What are the type of, ding, 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 ding. So yes. So
eccentric, she said.
Eccentrically. It's not a primary mover. You were saying antagonistically, eccentrically providing control. There's no active knee flexion happening during the squat. This is a passive. My knee's flexing because my ass is going to the ground, going to the grass. This is gravity knee flexion.
So we had, Sean asked if activating the quads would reciprocally inhibit the hammies.
So reciprocal inhibition is the phenomenon. It's a neurological phenomenon where when one muscle is activated, the antagonist is essentially deactivated or diminished. So, Sean, I will apologize for my response right now because I'm a physical therapist, and the answer to most of our questions, especially to the students, is it depends.
It depends.
Now, the students who get cocky and try to fire that back at me without an answer, you can't just say it depends and not have a reason. So, Sean, that's a good something to be asking. Reciprocal inhibition is a concept or a phenomenon that we generally use and we leverage during active stretching when we're trying to increase the range of motion of a joint. So for instance, if somebody's having trouble getting into knee extension because of pain in their knee and the hamstring is guarding and resisting and impairing the ability for the knee to extend, we will use reciprocal inhibition to turn on the quad to reduce the guarding of the hamstring in order to increase that knee extension. So that's when reciprocal inhibition will be used in a clinical setting, and that's in probably some of the stuff that Hannah that you do when you're working with patients, with your clients in massage. And so that's the clinical use of reciprocal inhibition. In dynamic movement, that's less of what's happening. But that doesn't mean to say that it's not a tiny little part of what's happening. Does that make sense?
Cool. Good explanation.
Is that helpful? Okay.
There you go, Sean.
Yeah, that was a good question. Now
can we figure out where we were going before that?
Thanks for the nerdy words. Okay, no, we're just astrograph. So what we were doing, we were identifying what muscle groups are happening because we're just remembering how to see a movement and identify which muscle is the primary driver. So astrograph, we've got calves are lengthened, the gastrocsoleus complex is lengthened. The anterior muscles in the lower leg are shortened. The quad, the rectus femoris specifically is maximally lengthened. The quads are lengthened because of the knee. So we're looking at knee flexion. Knee flexion lengthens the quads and the rectus femoris specifically. The hip flexors are maximally, with the exception of the rectus femoris, the maximally shortened because they cross the hip and the hip is maximally flexed. The extensors, if we want to go above the pelvis, the back extensors are lengthened. The abdominals are shortened. So I'm just kind of trying to encourage you to look at people from from a more of an anatomical knowledge of the musculoskeletal system perspective rather than just that movement. So just be thinking to yourself, ooh, what muscle's doing that? And that'll help. So what did I just do? What muscle just did that? What happened? I just straightened my knees. No, wait, what muscle does knee extension? Quads. What muscle does hip extension? Yay, that's good. So that's, I just reframing your thought process. So if you want to increase the length of the rectus femoris, ass to grass dynamically, from a dynamic perspective. What other exercises? We talked about goblet. We talked about some goblet stuff here. We talked about some goblet stuff for ass to grass, getting our rectus, but also, what else am I doing here? Now we can talk, let's talk a little bit above the iliac when you're doing a squat. Now what's happening? If you're up here, what muscles are activating above the pelvis? So what does core mean? What muscles are the core composed of? So what muscles are in the core? What are our abdominal muscles? The deepest one is the who? The transverse
abdominis is your deepest.
Yep, and then what?
Internal obliques.
And which one goes which way? Randomly? So internal, hands in your pocket? Yeah. External is your coat pocket. Oh yeah. Superstar. Sorry. So let's just go through. I don't mean to bust your chops, Sydney, because when people, as a physical therapist, core is just. It doesn't make it doesn't that it's such a overused term. It doesn't necessarily indicate knowledge. So the core at best day we'll go through. We've got our transverse abdominis, we've got our obliques,
internal, external.
Okay, and then rectus abdominis. Okay, so that's our abdominals. And then if we want to talk about the posterior muscles. So quadratus lumborum, and what does that do? What is that connected to?
Connects the pelvis to the lumbar vertebrae and thoracic.
Okay, so.
Bottom thoracic.
Okay, so it goes here. So what, if it shortens, what is it doing?
Both of them working at the same time or one side?
Oh, yeah.
So if we're doing one, we're getting or lumbar flexion or a hip hike, depending on whether it's closed or open chain. Okay, so this is really good. So what else is happening? What other muscle what other muscles are in the core? QL, what else is in the QL region? That everyone, but that's not a muscle. Fascia is an inert structure. It is an inert structure. It doesn't create movement.
So
it does not contract.
All your lumbar, you could do erector spinning,
And what action do all of those do? Yes. Yeah, and so like kind of the catch term can be paraspinals, the muscles that are along that paraspinal. So, and that would be the iliocostalis, the multifidi. That's getting kind of intervertebral, not like globally. So yeah, so you have, let's just go with back extensors, paraspinals, the quadratus lumborum. What other muscle is in there that connects to the lower 5 vertebrae and attaches to the inner
so
upper,
as you were saying,
the ilia who?
the psoas.
Ilia psoas, another muscle that gets blamed. It's the victim, not the perp.
Do you include pelvic floor? I've been taught that.
Well, what do you think? Is it between the pubic bone and the sternum?
I would include it.
Yeah, okay. So when you say core, be educated as to what you mean, because it means different things to different people. And then that will also help you to be able to fine tune kind of what it is that you're looking at. And so the piriformis, quadratus lumborum, so all of these are what allows you to do what movement when you're performing a squat. I'm going to help you. So if somebody's squatting like this versus squatting like this, which global muscle group are you going to maybe be thinking is weak? If they're collapsing, because which direction is this in the spine?
Flexion.
So that would tell you what muscle group is not working. The extensors. So that's the thinking to start to be fostering with yourselves is, okay, they're doing that. Rather than kind of spinning and getting like overly thinking about exactly what's happening, if you're simply understanding if this movement is happening, these muscles do the opposite, let's work on those muscles. You don't have to spin and try to diagnose or anything like that, because that's really a little bit illegal, but it's not efficient for you to do. So how do we screen for whether or not somebody has the abdominal strength or has the mid-thoracic region strength to be able to perform the squat? We're just going to review. Where's the, I don't know where.
What are you looking for?
Something with a...
Muscles?
I just need a stick. So the same thing with the ankle. If somebody's heels come up when they're doing the squat, and this isn't diagnostic, so it's within your scope of practice. If their heels come up and they do like this, and then you do that, and they're fine, then you're good. Oh, thank you. The same thing with the squat. If they first, because sometimes it's people just don't know how to move. And I'll say it, motor moron is a term that I shouldn't use, but we do use it. I am one of them. I've had people say, I will say, bend your knee, and they do this. Yeah. Stretch your hamstrings, they do this. Yeah. So, but people can't help it. Like, everyone has different body awareness. So if somebody is not able to do a movement, don't just immediately think, oh, they can't do that movement. Just modify it a little and not, with your understanding of anatomy, and see if you can help them achieve it based on your understanding of anatomy. So you say, hey, go ahead and do a squat, and they do this. But you hadn't really seen indication of them being abysmally weak in the core.
You just asked for a squat.
You just squat, oh, okay. Without a lot of words. You don't have to use a bunch of words. Say, okay, try this. And if they can do it this way, what does that tell you? They have the strength, they just didn't know how to do it. Now, if you have them squat, and you put, because what does this do? It puts you into what motion? Movement? My spine is doing what? Yeah, I put them into spinal extension to counteract the excessive spine flexion that was happening here originally. So too much spine flexion. We put them bias them into spinal extension. If they can do it, that tells you that they have that available, and they might be fatiguing out, they might just not know how to move. Then you take it away and just say, okay, now do the same thing, and if they are able to do it, now you know, they just needed to have a little cueing. Now, if you put this here, and they still stay here, that's more likely a weakness thing. So then what do you need to do? Pitch squats completely and have them lay on the ground? No, just shorten the squat. to what they can do. So if you notice that they can go, so don't be afraid to modify. If you notice that they can go here with good form, but once they go past here, they collapse, but your ultimate goal is for them to have them do this, don't do something completely different. Do it in the range that they can. Stay here, maybe load this a little, right? So just change the range, the arc of movement, and now you're training them to do what it is that you want them to do in the first place. Rather than get scared and think, oh God, they can't do it, they're not strong enough. Just change it a little bit, fine-tuning. Okay, so we talked about, we still haven't even gotten to glute med. So Q, you had said earlier, 7 tangents ago, that is the glute medius a part of the core? What do you think? Is the pelvis a part of the core? Does the glute medius affect the pelvis?
Yep.
Absolutely. Glute medius also affects the knee. So the glute medius, whether it's open or open chain or closed chain, if it's open chain, we're getting hip abduction, external rotation in the sagittal plane, not in with hip flexion. Now this is all hip flexors. If it's closed chain, meaning the foot's on the ground, you're getting you're getting the pelvis dropping. So this is closed chain, this is open chain. Does that make sense? Okay, very good. So let's talk about my favorite standing glute med progression. One guess on the first one that I'm going to have you guys do.
Is there a band involved?
One guess. Hell no. What does the deadlift do? Oh, well, I guess that's actually pretty complicated because it's one leg. Heck yeah. You get a band.
Uh-oh.
You get a band. You get a band. Everybody gets a band. Oh,
Band's
oh,
going
I
all
like how she
around.
grabbed the easier one. Everybody come out here and do our bands. Okay. So what does the band around the knees do? If you are resisting the band so above the knees, just to be, I know you're trying to do it harder, but don't do it the hardest way. So if we're doing the gunslinger move, which is one of my patients taught, gunslinger, so we are externally rotating, abducting. Now, yes, so my hips, if you're doing a quarter squat, yes, the hips are flexed. So you might think to yourself, oh, is that hip flexion? And we're taking the glute med out because it's hip flexion, because we're using the hip flexors? No, because your hip is flexed. If your hip is flexed, are your hip flexors passively sufficient or passively insufficient? Are they shortened?
Yes.
So then they're not the major driver. So if you're in a quarter squat and you're abducting and external rotating, you're activating your glute med. And then the best thing for you to do is to tell your client what is supposed to be sore or feel like it's working. So where is the glute medius located? Posterior lateral. It's kind of right here, actually. So point to right here and say, I want you to feel like this is fatiguing, because they're the best ones to tell you what's happening. Because we want to remediate glute motor morons. We want them to know I'm using my glute med. So we don't want to go past the second toe, because if we go past the second toe, so we see somebody, they do a squat and they're going into varus or valgus. If you have them do a squat and their knee goes past the second toe, what did we now just create? The exact opposite problem, varus. So, and that's rotation and external rotation and twisting forces in the knee. So you're creating a whole other curmudgeoniness,
Ain't
which
nobody
isn't
got
really
time
a
for
word.
that.
So that's not, so you're creating. So the knee, that's not a word, but so if you're going to do your glute medius activation, this patient, the client needs to be mindful of where their knee is in line with. It needs to be in line with the second toe, and they're externally rotated and abducted. If their knees go past that, you either cue them to not do that, or they need a heavier band. If they're blowing past it, the band isn't hard enough. So like Sydney, you might need a heavier band, depending on what's happening. And then we're also going to get our foot lift, kind of, but that's a whole other conversation about the short foot and all that, but their feet need to stay on the ground. So first things first, we've got glute activation, glute medius activation in the squat, and then do whatever squats. You're not going to do, why are we going to not do ass to grass with this? So feel, say that out loud.
It gets passive at the bottom.
Excellent. Or is it the bottom? Is it once you pass 90, yeah, correct. And that's what you meant. Yeah. Yeah, and so it's not, you're not, the glute medius aren't fully active past about 90. So, yep. So you keep creating a varus force, which is not what we're trying to do. But yeah, I mean, if somebody wants to be like a frog and there's some reason the work, I don't know, in some vocation or like I don't know when this would be an exercise that you would do with a human, but at any rate, it's not what we're looking to do. So if we want to maximize glute medius, first things first, you can be doing one position, sustained, isometric. So if they're resisting against the band, that's concentric, eccentric, or isometric. Isometric. And now you're doing a multi-joint exercise. So now we're getting the glute max because we're doing knee or hip extension, hip flexion. The glute max does not do hip flexion, it does hip extension. But what does that also do then? It's teaching that muscle group to work synergistically in the way that it's supposed to. When you're walking, your knee's not supposed to come in. The glute max and the glute med need to be working. So that's like neurological education, but just something to be thinking of. So first you start off, so this is the easiest. You could load it. You can add load, like if you want to be working, if you want to really be bang for your buck, you might be noticing I'm always putting a weight in somebody's, if they're doing a squat, if possible, I'm putting a weight in their arms so that we could be maximizing what they're doing. If I'm going to be doing specifically just the glute med and the squats, it's usually because I'm doing more of a physical therapy intervention, motor retraining, neuromuscular reeducation, more of like a specific something. But if you're doing from a fitness perspective, you're almost doing, if they have the strength to do it, you're almost doing them a disservice by not putting weight in their hands. So, Kwame. Come back. So goblet.
That's my hero right there.
Oh God. Guess who gets the 30 pounds? You got it.
Keeping your knees safe, man.
I don't know if I can do, well, I'll try 40, just to be a team player. Oh, you're a good man. Okay, you're a good man. So think about this. So if I say to you, hey, work on their glute med strength, what else is happening here? We just talked about all the muscle groups that are activating during a squat.
All of my core muscles.
Uh-huh.
Glute medius.
You're using your entire body. And you're distracting them from the using of their glute medius, so that you're training them to use their glute medius unconsciously.
And I can feel the hamstring on the eccentric.
Yeah. Now that you're loaded.
A little bit of laps.
I definitely need a heavier band.
Yes, you do. Yeah. 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 Or for you, you might, yeah. No. No. Because now the glute medius is shortened and it's passively insufficient. So understanding of anatomy, just know that if you were working glute max.
Wouldn't that also stress the medial side of the knees?
Yes, if they're going into valgus. If they're keeping here and you're going into a squat, you're maximizing the glute max. That's more of a sumo squat. But just understand your anatomy. Passive insufficiency is when the muscle is shortened and isn't able to create force. lengthen insufficiency is when it's too long to do anything, and so it's at the end range. So a muscle needs to function during the mid-range. Okay, so I guess the moral of this story is I would really try to be mindful of not doing single joint exercises or single body region exercises. The vast majority of your people should be doing full body activities, if at all possible.
Thank you so much.
Oh, you're welcome. And then understanding from an anatomical perspective. Wait, don't lose your, Hannah, you're missing my favorite. This is my favorite series. Okay, anyhow. Okay, so let's go, you can put that stuff. Let's put that stuff down. Okay, we're probably running out of time. Ooh, look at my thing.
Yes, you are. We have gone an hour, so if you
Okay, very good. I just wanted to go through my standing glute med, put it back on. Glute med series. So go ahead, you can put the weights down, but here is my latest favorite series for glute med if we're going to be focusing on one region. But this is much more complex. I use this on my CrossFit athletes who are super strong, but they're weak in key areas. So again, glute medius does what action? In what plane?
Sagittal.
Yes, the frontal plane. So here, not here. Yeah, I misspoke when I said sagittal earlier. The hip flexion is sagittal. Hip abduction is extension or frontal. Okay, so here's where we're at. Hands on hips so that the person is aware of whether or not they're hip hiking, because if they're hip hiking, they're dropping a pelvis, and the glute medius is either not working or overworking. So we start off with cueing the person to be in a little bit of a micro bend, and then we'll just be providing them with some support. So they're just going to come into abduction, meaning straight out, and their toes are going to be kind of straightforward. And I know you're thinking to yourself, but it does external rotation, but that actually, in this position, it's passively insufficient. So I'd rather have it be fighting against. Anyhow, so toes forward, tap out, and tap at 45. But they also need to keep that standing knee in line with the second toe. So they're resisting the valgus on their standing leg, and they're actively in an isometric perspective, and they're actively activating the glute medius with the moving leg. So generally the person's going to start to fatigue on their standing leg with this one, but because it's dynamic, you're helping with functional activities. Okay, so once they've got this one, which is static with the standing leg, now we're going to open chain it, because this is kind of this is the door half open. The chain's not closed, its chain's not open. Like it's open now, but now it's closing. So it's a little bit of both. Now let's open the chain and make it a lot harder, and we're going to go into neutral, so no hip flexion, abduction, and then you're just going to externally rotate. But watch your knee, the standing knee. Look in your mirror.
This band is like...
So you have to look at the standing knee, keep it perfectly, you're resisting valgus, so that's, I know, right? You're wishing you had the green one on. So now the knee is in line with the second toe, and then you're abducting and external, and all you're doing is once you abduct, all you do is external rotate. Keeping that standing knee in line and not getting into hip flexion with the moving leg. So Sydney, we're having a lot of pelvis rotation. So less is more with the movement here. You're really only, so put your hands on your hips so you know where your pelvis is. And then you come into abduction in line with the other femur. Wait, I'll show you the other one real quick. Now we're coming into external rotation without your pelvis moving. So all you're doing, external rotation, and it's not a big movement.
Okay.
And now you're keeping that first knee where it goes. This band is too hard for you. It's super heavy for you. If it was the green one, your knee would be further out. But the key is you're not doing a big external rotation. You're not doing a big, huge this. You're here, and you're just coming just as much as they can control, okay? This will freak out a strong athlete because there's a lot. And then you take it to another level. You add a dynamics to that other one, the first one. So now we're bending the standing leg, and they're having to come into a semi-squat. And now you're a lot more complicated because now you are having them keep the pelvis level. So they're not doing this. This is compensating. They need to be bending the standing leg and bringing the moving leg out to the side. Bending the standing leg, bringing the moving leg 45 degrees back. So all of this stays perfectly still, and they're moving. So they're doing a mini squat and controlling. So you're not moving your standing leg, Sydney. So for the first one we did, you kept it still, and all you were doing is moving the moving leg. This one, you're doing a squat. You're doing a full, nope, that was the first one we did. But you have to watch put your hands on your hips so that the person can feel when their pelvis becomes unlevel. So on your iliac crest, Sydney, so you can tell when you're doing this. There you go, perfect. Yeah. Oh, that's hard, right? Yeah. So those are the cues. So, and then have them watch in the mirror so that they can modify. So you need to be able to do this. And so the best thing for people too is to help them figure out how to do it themselves. So see how you're wanting to valgus, that standing leg, and your butt sticking out? Yeah. And see how that really is helpful to have your hands on your iliac crests? Because you can feel when things go wonky. So I know this seems really easy, but it's hard. Oh, so all of my CrossFit people who are having, they can lift, they can do Olympic lifting, a back squat with 280 pounds, but they're having trouble with the valgus, with the dynamic movements. I'll have them try to do this, and they don't have the motor control for it.
Thank you, Tonya.
Oh, you're welcome. So this last one is what I was going to suggest for the fellow from the other day.
Okay, I'll watch it.
Yeah. I'll send you some notes. I'll send you the link. But yeah,
Absolutely.
I'll send you a little overview. But I think we covered a lot of what. Was that helpful?
Oh, yes. Most definitely.
I know, right?
I'm just forcing the valgus to resist the band. Just gotta.
Yeah, just be aware of what you're looking at. And even if a person isn't able to perform it with minimal cueing, if they're not, and with looking at themselves in the mirror, if they're still not able to perform it with proper form, then it's just too challenging for them at the moment. So you can either do an easier band or just make the activity less dynamic. That's all.
Hands on the hips are the key.
Huh? The hands on the hips is critical because people need to feel, because if they don't know, because then they're going through their day and they're like doing stuff that's hurting their knee. Like you do all this work while they're in the clinic, or they're in here and you're teaching them to get stronger, but they don't have the body awareness to avoid the position that's hurting them, then you're doing them a disservice.
Especially like when we're doing the stuff on Zoom and they don't have the mirror.
Right.
That's a good way to
Can they? But they can see themselves on the Zoom.
Right, yeah.
Yeah, so that's helpful. Questions, comments, concerns from the peanut gallery?
Could you just give us your Tonya take on? I've seen quite a few trainers pulling apart, like pulling away, so they're forcing valgus or varus. So like, if Yesenia was holding on and you were pulling in, when would that be appropriate?
When you want to increase the valgus force.
Okay.
Because what muscle group are you strengthening by doing this?
Adductors.
Correct. So when do you want to strengthen adductors?
I don't know when. I mean, I feel like they're just so, like, from a physics standpoint, everything on the
Nobody
outside.
knows why the adductors are so massive.
Yeah.
From a kinesiology.
Yeah, it's
Like nobody knows why there's so much muscle mass here, other than just to piss off women, because you feel like, you know, your pants, like, you get the chub rub or whatever it's called.
chub rub.
Because the chubby rub, anyhow. And this Florida, you get the sweaty thighs. I'm trying to think.
I mean, I imagine there's some people that are
I don't know.
genuvalgum
I
or
don't-
genuvarum that might need it, but
I don't know that I don't know when in the context of a personal trainer that you would want to be increasing the strength of the adductor.
so
muscle
some
group.
people work out on the machines where they focus on that, so they
And
might
that
be
is
wanting
women who are trying to reduce
right, which we know that's
their thigh girth. So they're when they're doing the adductor machine, they're really comfortable with themselves, looking splayed in public. I know it sounds weird. I'm too modest to do that. Like, for one, it doesn't make any sense. It doesn't. No, I think in the workout machines. Oh, so thank you. In the adductor workout machine, the vast majority of time women are using it is because they're trying to reduce the bulk of their inner thigh. But there's no. I'm trying to think of like what kind of a sport or activity that you would do where you would need to increase the strength of the adductors. I can't come up with one. There probably is one, but in the grand scheme of things, in the personal training world, there's really no reason to increase the valgus force through the knee.
okay.
And because often, yeah.
I didn't know if it was, you know, maybe to help this. I've never seen a real purpose. When I started realizing how weak the glutes and the adductors are, I don't see any reason to reinforce what's pulling against them.
Yeah, so women in the gym are trying to slim down their thighs when they're doing this. Because my mom had the one where it was like the spring-loaded thing, and you did this. So that's where women, when women are doing that, they're trying to reduce the girth of their thighs. I don't.
Almost like a band
Yeah,
with a ball in the middle.
That's just people who don't know what they're talking about selling something to people who don't know what what they're listening to. It doesn't really make any sense. But it's. I mean, my mom had the Thigh Master 50 years ago, and so that's not a new thing. It's just recirculating. But people are trying to reduce the girth in their thighs. There was something else where I was going to go with that. There was a tangent.
Yeah, so you need to rewatch the beginning of this video.
Adductors. There was somewhere I was going to go with that, Chris. I can't remember with the adductor.
Can be
the
useful
thigh.
for lateral cutting movements, soccer, hockey, etc. Said by
So
Sean,
if you're laterally cutting, you're not pulling your leg in with your adductors. You're supporting that's a good question. I really like it. And I might nerd out a little bit in a second. In the cutting movements, the stability is conferred through the glute medius to prevent that valgus force, primarily, and the strength of the glute max for the hip extension. But when you're cutting, your knee is not coming in because of active contraction of the adductors. You're being stabilized because